Okay guys, sorry. So today we are going to learn SDS live chat coding demo and we are going to learn spinal procedures. So always my intention is to share knowledge, gain knowledge. Okay. So as we have discussed, I am having two YouTube channel. First one is FastCoder21 English Medical Coding YouTube channel and next one is SuperCoder21 Telugu Medical Coding YouTube channel. So currently FastCoder21 has 12,800 subscribers. In SuperCoder21 I have started like 2 weeks back. Currently it is having 90 subscribers. Okay. So FastCoder21 is the one of the top most YouTube channel in India, especially related to medical coding in all specialties. So if you see outside, we are having YouTube channels. Mostly they will concentrate on only CPC point of view. But I will not concentrate on CPT point of view. So my concentration is always on live coding. So whatever I will teach on my YouTube channel, everything is related to live coding which we will encounter during our live chat or live specialty codings. Okay. So currently I am working as a ambulatory surgery auditor cum trainer and I have started this YouTube channel 3 years back. Next, today we are going to learn disc herniation. Okay. So most of the time in the ambulatory surgery coding you will encounter disc herniation. For that physician will perform arthrodesis. Okay. So before going to learn this disc herniation, we need to understand the anatomy first. Okay. So first we will learn the anatomy. Next we will go to our CPT procedure. Okay. So this is the lumbar spine side view and this is the pinched nerve. Okay. So if we see this one, this is the healthy disc. This disc divides into two parts. Middle part is nucleus pulposus. So surrounding this middle part is annulus fibrosus. So middle part is nucleus pulposus. Surrounding this nucleus pulposus is the annulus fibrosus. So this is the herniated disc. So here we need to understand what is disc herniation. Okay. So basically the other name for disc herniation is slipped or bulging disc. Okay. So what happened during this disc herniation? This nucleus pulposus will protrude or push through the annulus fibrosus and it will create pressure on the nerve. Okay. So this is the nucleus pulposus, correct? This middle one. And this nucleus pulposus will push annulus fibrosus. This is the outer layer. And this annulus fibrosus will create like compression on the nerve. So due to that, patient will have pains or chronic pains. Okay. So in order to reduce this disc herniation, physician will perform the arthrodesis. Okay. So today we are going to learn arthrodesis procedure. Okay. So what is arthrodesis, guys? Anyone knows arthrodesis?
Joint fusion.
Yeah, arthrodesis is the joint fusion. The main purpose of arthrodesis is to limiting the movement of the joint. Okay. So here patient will remove this disc and he will limit the movement of the disc here. Okay. So because of that reason, patient will not have any pain or touching of this bulged disc on the nerve. Okay. So as there is no bulging here, that bulging will not touch this nerve and patient will not have any type of pain. Okay. So the other name for arthrodesis is joint fusion. Okay. Here physician will remove the disc material. So if you go to interview, they will ask you what is the difference between intervertebral disc as well as interspace. Okay. So the space between two vertebrae is interspace. In this interspace, we are having the disc. Okay. So if we see the spine, this bony part we will call it as vertebral body. This bony part. So this is the spongy part or cushion. We will call it as herniate disc material. Okay. If you go to interview, they will ask you what is the difference between vertebral body or vertebral segment as well as the disc. Okay. So just you need to tell them. So vertebral body or vertebral segment is the bony part of the spine. Okay. And the disc is the intervertebral disc is the cartilaginous material which will present in between two vertebrae. Okay. So this is the vertebral body or vertebral segment. So this is only this round part we will call it as vertebral body. Along with this posterior portion like spinous process, transverse process, lamina, facets, all this combination we will call it as vertebral segment. Okay. So if you see this one, this is the intervertebral disc which presents in between two vertebral bodies. This one vertebral body, this is another vertebral body. Okay. So this is the anatomy we need to understand while coding spinal procedures. Okay. So if you observe this one, for interview purpose, nearly we got 7 to 8 questions. So these are the mandatory questions they will ask in the same day surgery interviews. Okay. Next we will see the operative report. So here pre-operative diagnosis is herniated disc. Post-operative diagnosis also same. So same means here also physician is telling patient is having the herniated disc. Okay. So in order to remove this or excise this herniated disc and in order to remove the patient's pain, physician is performing the arthrodesis. Okay. So here we will see the keywords first. Okay. So a patient with C4 to C5 large central herniated nucleus pulposus presents for arthrodesis. Okay. So here patient is having arthrodesis or herniated disc. Which location, guys? Which spine? So
Cervical.
yeah, perfect. So cervical C4 to C5. Okay. So patient is having herniated disc in the cervical spine C4 to C5. Only one interspace. Okay. After obtaining informed consent from the patient, which included full understanding of the risk, benefits and alternative to surgery, the patients were taken to the operating room and underwent successful induction of general endotracheal anesthesia. Prophylactic IV antibiotics was given. So basically, whenever we code operative report, we no need to worry about the number of lines. Okay. So we need to concentrate on what is the exact procedure physician has performed. Why means most of the time if the physician is elder physician, so he will tell very lengthy documentation or he will provide lengthy documentation. But nowadays new doctors or new physicians they will provide very few lines of documentation. Okay. So whenever you code any orthopedic procedure, we no need to worry about the number of lines they have provided or which are presented in the operative report. The only one thing we need to remember or we need to understand, we need to identify the keywords. Those are very important in order to code any type of operative procedure irrespective of specialty. Okay. So here these are the common uh, topics every physician will mention. Okay. So bilateral compression hoses were placed. The patient was placed in supine on the operating table. So this is very important keyword for spinal procedures. Why means while coding spinal procedure, we are having different approaches like supine, prone, okay, lateral approach, anterior and posterior. Okay. So if we see supine here, we need to understand that we need to use the anterior approach. Okay. So basically supine means face up. So this is the synonymous for anterior approach. Okay. So here patient was placed on supine position. This is very important keyword in the operative report, especially whenever we code spinal procedures. Okay. So this is one keyword. 5 pounds of weight and roll under the neck and the shoulders. So anterior neck was then prepped and draped in the standard surgical fashion. So this is also very important. So whenever we code these spinal procedures, we are having different location of spine like cervical, thoracic, lumbar as well as sacrum. So what happens sometimes in the heading of the operative report, patient will tell lumbar, but in the operative report he will tell neck or cervical. Okay. So whenever in the ambiguity situation, we need to quote from the description of the operative procedure. We will not quote from the heading of the operative procedure. Okay. So as soon as you see neck here, we need to understand that patient is performing procedure on neck area or cervical spine. Okay. So other name for neck is cervical spine. So anterior neck was then prepped and draped in the standard surgical fashion. So a right para midline incision. So this is also very important keyword here. Okay. So here physician has prepared the neck and he created the incision. Okay. So upper skin crease and the dissection was carried down through the platysma. So this is platysma is the very thick muscle where physician will create small incision initially and he will dissect the tissues. So basically dissection means he will go down through the platysma. Okay. So blunt dissection. So what is blunt dissection? So here blunt dissection means basically physician will use the finger in order to remove the flaps or tissue. Okay. So blunt dissection technique was used to dissect between the carotid sheath and the midline structures to the paravertebral fascia. So basically using the blunt dissection, physician has dissected the fascia. Okay. So preoperative X-ray was then obtained to confirm the level of the surgery. So here physician has confirmed the location of the spine using the X-ray. So the longest colli muscle along both sides of the vertebral bodies was freed up using the bovic artery. Okay. And the clover retractor was placed under the muscle. So basically whenever physician wants to perform any type of procedure, he needs space to perform the procedure, correct? So for that time physician will use the retractor. So whenever you see the retractor in the operative report, we need to understand that physician is using the retractor, otherwise in order to open the surgical or surgery location, physician will use retractor. He will press the retractor so that physician will get the space to perform the procedure. Okay. So having identified the C4 to C5 level using the cross table X-ray, the disc space was incised and the disc material was removed in a piecemeal fashion with the pituitary ronger and curate. Okay. So here physician has dissected the tissues. After dissecting the tissues, physician has inserted the retractor on the cervical spine. Okay. And physician has identified the C4 to C5 cervical disc space. Okay. And here clearly is telling disc material was removed in a piecemeal fashion with pituitary ronger or curate. Okay. So this is confirmation that physician has performed the discectomy. Okay. So discectomy means removal of the disc material. Okay. Using the ronger and curate. Most of the time in the operative report, if you see ronger, physician will use this ronger for removal of the bone structures or thicker structures. Okay. So two Casper pins were placed and the Casper pin distractor was used to distract the interspace. The residual disc material were then removed with a curate and pituitary ronger. Okay. So again physician is telling I have removed the disc space. Other name for removal of disc material is discectomy. Okay. Next there was a posterior longitudinal ligament that was torn and several large herniated disc pieces were posterior to the PLL. Okay. So in this paragraph, physician has completed the discectomy, means disc plate or disc space removal or intervertebral disc removal. Okay. Next, a partial C5 carpectomy was performed. Okay. So as the disc fragment had migrated inferiorly behind the C5 body to safely retrieve the fragments and to ensure that all the disc fragments were removed. Okay. So after performing the discectomy, patient has performed carpectomy. So what is carpectomy, guys? Anyone knows? So yeah,
Main part of vertebral body.
yeah, perfect. So basically removal of cartilaginous material is discectomy. So removal of bone is or vertebral body, we will call it as carpectomy. Okay. So here also we'll see one guideline. So if you go to interview, they will ask you what are the guidelines related to carpectomy. Okay. So these are the guidelines. If you want to quote carpectomy for cervical spine, physician needs to remove above or greater than 50% of the vertebral body. Okay. In the thoracic and lumbar, physician needs to remove greater than 33% of the vertebral body. Okay. So this is very important interview question. So they will ask you what are the carpectomy guidelines. So that time you need to tell them. So in order to code carpectomy in the operative report, we need to check if the physician performs carpectomy more than 50% only, we will code cervical carpectomy. Okay. For thoracic and lumbar spine, physician needs to remove greater than 33% of the vertebral body. So how do you code, guys? If the physician performs 40% cervical spine carpectomy, will you code separately or not? 40%. So we will not
Will
code
not go.
separately. Yeah, correct. We will not code. Why means based on CPT, physician needs to perform greater than 50% of the vertebral body removal. But I asked you only 50%, sorry, 40% correct. So that time we will not code carpectomy. So we need to check if it is greater than 50% or not. Okay. So again, so a partial C5 carpectomy was performed as the disc fragments had migrated inferiorly behind the C5 body to safely remove fragments and to ensure that all the disc fragments were removed. Okay. So as this disc material went through the cervical vertebral body, physician has performed the carpectomy. Okay. So the uncovertebral joint was then decompressed bilaterally with curette and Kerrison punch until there was no compression of the nerve roots on both sides. Okay. So with the interspace distracted, a 9 mm structural bone graft was tapped into the C4 to C5 interspace under direct vision without difficulty. Okay. So previously physician has performed discectomy, correct? So in this para physician has performed the discectomy. Okay. So in order to compensate the discectomy procedure, physician has used the bone allograft. Okay. Structural bone allograft. Okay. So here also we are having very important interview questions. Okay. So basically we are having two types of bone grafts, allograft and autograft. Okay. And based on step, we are having two types of bone grafts, structural bone graft as well as cancellous bone graft. Okay. So structural means here physician will use the single piece of bone graft. Okay. And next one is morcellous bone graft, where physician will use the graft in the pieces, small pieces, like in the powdery palm. Okay. And allograft, autograft. Autograft means physician will take graft from the patient's own body. Allograft means physician will take graft from the other than patient's own body. Okay. So this is very important in order to code spinal procedure. So just try to remember, this is very important keyword. Structural bone allograft was tapped into the C4 to C5 where physician has performed the discectomy. In order to compensate the discectomy, Fishni has used the allograft. Okay. So after removing the Casper pins, the wound was then thoroughly irrigated with bacitration irrigation. Okay. So a 60 synthesis vectra cervical plate was placed between the C4 and C5 vertebral bodies for intrabody arthrodesis. Okay. So first step, Fishni has removed the disc material or discectomy. Okay. So after removing the discectomy, after or otherwise after performing the discectomy, Fishni has applied the bone allograft. Okay, this is the second stage. In the third stage, Fishni has applied the cervical plate on the vertebral bodies. Okay, in order to keep this bone graft in the space between the C4 to C5, Fishni has used the cervical plate between C4 to C5. Okay, so usually we will call it as interbody arthrodesis. Okay, why means as Fishni is performing arthrodesis between two interbodies. Interbody means between two interbodies. Okay, so here Fishni has inserted the cervical plate. A cross table lateral radiograph was obtained to ensure there was good placement of the screws. Okay, so as soon as Fishni will perform the insertion of cervical plate, Fishni has positioned the screws. So the clover retractor was then removed. Okay, so basically application of these vertebral bodies is important, or vertebral plate is very important step in arthrodesis procedure. Okay, so Fishni has removed the retractors, so the trachea and esophagus appear to be in good condition. Why means as Fishni is performed procedure on the cervical spine, so Fishni needs to take care about trachea as well as esophagus also. So the neurovascular bundle immediately lateral was also in good condition. The wound was irrigated with bacitration. Okay. So these are normal procedure. The wound was closed in layers using tuovascular suture and the platysma was closed using inverted interrupted trivovascular sutures at the dermal layer. So always one important keyword is whenever we code closures. So initially Fishni has like dissected the platysma, correct? Here we have seen. So here, so dissection carried down through the platysma. Okay. So if we see here, Fishni has closed that platysma using the sutures. So that is very important. So we need to check. So Fishni has like opening or closing is performed or not. So here Fishni has performed closing of platysma. Okay. So these are normal ones. We no need to worry. Okay. So next here we need to understand what are the codes. Okay. So for this scenario, so as Fishni has performed or created initial incision on the anterior side of the cervical spine. Okay. So we need to code it as anterior approach. Okay. So here we need to code 22554 for arthrodesis. If we check the code description 22554 arthrodesis anterior interbody technique. Why anterior here? Fishni has created incision on the neck.
Supine position.
Yeah, supine position or on the neck area. Okay, so that's why anterior. Why interbody technique? As Fishni has performed arthrodesis between two interbodies, including minimal discectomy to prepare interspace cervical below C2. Okay, so what is our cervical spine level? C4 to C5, correct? C4 to C5. Okay, so if you see code description, we need to use 22554 if the patient performs arthrodesis below C2. So this is correct code 22554. Okay, as we have discussed previously, Fishni has performed 51% of the carpectomy, correct? C5 carpectomy or cervical carpectomy. So here we need to code vertebral carpectomy separately. Why we are coding separately? As Fishni has performed 51% of the vertebral carpectomy. Okay. So here we will code 63081 vertebral carpectomy or other name for vertebral carpctomy is vertebral body resection. Okay, partial or complete anterior approach with decompression of spinal cord and nerve root, cervical single segmental resection of a single vertebral body. Okay, so per the operative report, the disc space was incised and the disc material was removed in a piecemeal fashion with the pituitary arranger and a curette. Okay, so as percentage is more than 50, we need to code 63081 separately. Okay, next, what is our graft? Structural bone allograft, correct? So this is the keyword. So here we need to use plus 20931 allograft structural for spine surgery only, because the patient prepared and inserted an allograft here. So based on the operative report. So this one. Okay. So next we need to code anterior instrumentation. So what is the keyword for anterior instrumentation? This one. So this one. So a 16 mm Synthes Vecta cervical plate was placed between C4 and C5. Vertebral bodies for intra-body arthrodesis. Okay. So this is the anterior instrumentation. So for that we need to code this one 22845. So these anterior instrumentation codes are based on number of vertebral segments. Okay. So see here for the anterior instrumentation of 2 to 3 vertebral segments. So we are having how many vertebral segments, guys? 1 or 2? So tell me also among C4 to C5 how many interspaces and how many vertebral segments?
Two segment, one interspace.
Yeah, perfect. Yeah, 2 segments, 1 interspace, correct? So as physician has performed application of this cervical plate, we need to code this one. See here code description 2 to 3 vertebral segments. List separately in addition to code for primary procedure for the anterior instrumentation of 2 to 3 vertebral segments. Okay. So these are the 4 final codes we need to use for this chart. Okay. So what do you learn in this training? So first we will learn modifiers with example scenarios. Why means if you go to interview, modifiers with examples are very important. Why means mostly they will ask you one modifier and they will ask you to provide an example scenario. So that you will learn. And also you will learn NCCI edits. Okay, so we are having basically 3 types of edits. You will learn all those edits during our live session. And whenever you want to learn like any type of operative or same day surgery coding, you need to understand surgical instruments. Okay. For example, previously we have seen ronger, correct? So we need to understand what is the purpose of ronger. So we need to understand that one. So before starting live chats, I will tell you common surgical instruments and also I will provide types of incisions. So why means based on the incision also we can understand what procedure physician has performed. Okay. Not only using the post-op diagnosis, based on incision also we can learn what is the procedure physician has performed. Okay. Next, I will teach you surgical positions. Okay. For what is the position for OBGYN procedures? What is the position for colonoscopy procedures? What is the position for EGDs? Okay. Next, I will teach you OP report components. Okay. So what are the components? Basically, if you see one OP report, nearly you will see 20 components. Okay. So I will teach you each and every component and I will teach you what are the important things or what are the important keywords you need to code from that components. Okay. So I will teach you choosing keywords from operative report as we have discussed now and also how to lead index. Okay. So I will teach you step by step. You don't need to worry. Just I will tell you, just you need to follow that. That's all. Okay. So I will tell the main word or keyword. You need to follow that one. That's all. Okay. We are having basically multiple approaches to learn surgery coding. Okay. So during live coding, you will learn everything. Next, I will teach you 3M software with Epic. So if you go to interview, na, So they will ask you, do you know 3M? So after this session, you can tell the interviewer that, yes, I know 3M and also I know Epic software. Okay. So this Epic software you will not find outside. So this is very confidential. So that one I will teach you, Epic software. Okay. Next, here you are going to learn live charts nearly 40 to 45 with index leading. These live charts include 10,000 to 60,000 series. Okay. First, for example, if you take integumentary section, first we will learn the most important topics for interviews. Then we will learn live charts. Okay. Theory plus live chart. Every chapter is like that only. First theory, then live chart. Okay. Next, very important Q&A for interviews. So at last, we will learn nearly 400 to 500 interview questions. Okay. So 95% in the interviews are, they will ask these questions only. Okay. So and also we'll learn updates related to ICD-10 CM and CPT 2025. Why means whenever you go to interview, they will ask updates also. So it is very important to understand the updates also. So I will teach you ICD-10 CM and CPT 2025 updates. Okay. And also I will provide specialty trainings like dermatology, orthopedic surgery, respiratory system, cardiothoracic surgery, IVR surgery coding, digestive system coding, urinary system, OBGYN, nervous system and pain management. So basically these are the specialty trainings. You no need to worry. In this training you are going to learn each and every system. Okay. For example, if you take dermatology, nearly you will learn 8 to 9 live charts. 99% you will code those live charts in the live coding. Okay. So next, any questions guys? So if anyone looking to have free APC CE webinar links, or if you are looking for medical coding jobs in USA, UAE and India, please join in WhatsApp group. I will provide WhatsApp group link in the description of this video.